have this. This is not an unreasonable number of data exchange partners for the typical health information exchange to have this number of records of a single hypersensitivity condition. And look what we missed that was not on page 1 and was probably on page 3 was a radio contrast allergy to which the patient has a history of anaphylactic shock. And oh, by the way, anaphylactic is misspelled here, which is another challenge with respect to the semantic problem, is that there's multiple misspellings and variations of terms that you have to negotiate and stay on top of. So this very extremely important allergy, especially to our radiology department staff, is buried in the mountain of information, and the semantics helps us bring it up front and center so that key decision makers have it right in front of them so that they do the right thing for the patients. And also it's a more usable display because with one look I have all the information I need, and we've reduced, we have one line of information per key piece of information that we need, which is we have one line of information per hypersensitivity condition here. With respect to laboratory tests, we had a similar problem with each hospital having a different code for the same laboratory test. So we had 13 hospitals with different codes for the same thyroid stimulating hormone test. And you can see the various test codes that are listed here, such as TSH12, TSH, TSHQ, and all the way on down to Quest Diagnostics, our commercial laboratory partner, which has a code for that test of 3012. And since we've done this, since we did our phase 1 work with laboratory, we've since integrated or done the planning stages and preliminary work for integrating LabCorp, and they have yet another code for TSH test. So why is that a problem? Well, if you're looking at a long list of laboratory test results, you can see here that we've got multiple pages of test results, and on page 1 we see that the patient has a 3rd generation TSH result, which is low, and in this demo patient we created to have hyperthyroidism, which leads to a low TSH. And you just see here the TSH results from Quest. And again, if you click on that result, you only see a history of one TSH test result. You don't see TSH test results from any other laboratory. When you go to page 2 of the laboratory results, only then do you see that the patient has a TSH test that you can compare historically from SunQuest, our SunQuest laboratory system, which came from one of our hospitals. And when you click on that test, you see that the patient has 3 results. So to trend those over time, you would have to manually, in your head, compare the Quest result 3 screens ago to the SunQuest TSH results on this screen to get an idea of what the patient's thyroid activity has been over time. When we do the translation of the test codes, when we assert the equivalence, and I'm going to jump back here, although I know this isn't great, but if you assert the equivalence of all these codes in terms of what laboratory test procedure they identify, only then is it possible to see all the patient's TSH tests on one screen. And this also has critical importance for, again, our radiology department staff when they want to see the patient's kidney function over time and look at the laboratory tests historically over time for, again, the BUN and creatinine results. And there's a million other examples that would be easy to come up with. I also mentioned I would talk about clinically relevant displays. And here's an example of a clinically relevant display for congestive heart failure. So what all information does the physician want to see at one time when he's taking care of a patient's heart failure? Well, he wants to know the patient's ejection fraction. He wants to know the risk factors that patient has for other cardiac diseases like coronary artery disease. So he wants to know that the patient has hypertension, hyperlipidemia, type 2 diabetes, the CHF diagnosis itself, family history of coronary artery disease. He wants to know all the medications that's relevant to patients with heart failure, so he wants to quickly be able to know if the patient's on an ACE inhibitor or an angiotensin receptor blocker, such as lisinopril. He wants to know what beta blocker the patient's on. and he wants to know what antiplatelet drug the patient is on to avoid stroke risk. And he wants to know what cardiac tests the patients had done, such as EKGs and echocardiograms and stress tests, and he wants weight over time because that's important for heart failure patients. So a sudden increase in weight could mean that they're retaining fluid, and you can prevent them from coming into the hospital potentially if you get that extra fluid and water weight off of them with the diuretic. And he wants to see laboratory results relevant to heart failure, such as the basic natriuretic peptide, or BNP, which is elevated in patients with heart failure, cardiac enzymes, the patient's electrolytes, renal function, there's the BUN and creatinine at 13 and 0.8, and the patient's lipid profile relevant to their hyperlipidemia and their hemoglobin A1C relative to their diabetes. So in one screen, here the clinician has just about everything he or she needs to care for a patient with heart failure. You don't, at least I have never seen a view like this in a typical electronic medical record. So this is extraordinarily helpful. And the way the semantics helps us get here is we can create relationships between heart failure and all the other and its risk factors, and we can create relationships between heart failure and the medications that treat it, and we can create relationships between heart failure and the laboratory tests that are relevant to it. And we can dynamically update without recompiling the source code these types of views. So if a new laboratory test is invented tomorrow that's relevant, we create that relationship, put it into a vocabulary or semantics management system, and suddenly that laboratory test will appear on this view without having to take a code upgrade or recompile the code at all. So to summarize the talk, the lessons learned, semantic interoperability, I think it's safe to say, is as difficult, but maybe not quite as hard as we thought it would be. One of the things I meant to mention earlier with respect to the laboratory test code and medication and allergy code translations is that a very small number of codes make up a large percent of the volume. So we found that when we translated about 74 laboratory tests made up over 75% of our laboratory test volumes, and we had 180 million as of I want to say May or June of 2009. We had 180 million laboratory test results in the DB Motion system, and 140 million of those we could make semantically interoperable by just translating 70 laboratory tests from each hospital and commercial laboratory. We also learned that the semantics were worth the effort. The trending over time and the semantic grouping of allergies, and we also, what I didn't show is the semantic grouping of medications, but our clinicians really liked that, and it was a highly rated positive feature of the system. And to get there, though, our keys to success were scoping the effort and finding, again, where, as I'll say on the next slide, where our pain points were with fragmented data and what we could deliver early to address them. And a nice surprise in terms of a key to success was reducing information overload with the semantics. So to deliver value quickly, then, we would say the first step is to determine what are the key or most critical pain points as a result of your fragmentation of your data, and then determine of those pain points which ones can you integrate quickly to generate early wins, and focus on the intersection of those two things. And again, with respect to the semantics, you can go a long way with semantics by translating a very small percentage, 5% of the codes in any particular domain area, like your laboratory test codes or your medication